Hello friends, today's topic of discussion is intra-aortic balloon pump. Intra-aortic balloon pump mechanics studies first demonstrated the utility of the Iabp and counter pulsation in 1958. The device was used clinically just one decade later. The Iabp facilitates the diastolic augmentation to increase coronary blood flow and LV systolic work offloading to decrease the LV work. IVP consists of console, which is responsible for delivery of the volume of gas, catheter, and bulb. Intra-aortic balloon has uniform construction, although there are variations in the membrane length, inflated diameter, and the balloon volume. The balloon is rapidly inflated and deflated by injection and retrieval of the gas, typically helium and carbon dioxide. Helium, which is inert and is the preferred agent because its lower viscosity, it reduces the resistance and increases the laminar flow, allowing for more rapid gas entry and retrieval. Optimal balloon sizing requires so that no more than 90% of aortic diameter is obstructed when the balloon is inflates. Although in clinical practice, the aortic diameter is infrequently measured before the insertion. Improper sizing carries the risk of oversized balloon and increases the risk of vascular complications. Whereas undersized balloon will offer the suboptimal cardiac augmentation. In majority of cases, 40 ml balloon is appropriate and should be used in patients 162 to 182 centimeter tall. Use of 50 ml balloon should be considered in patients who are more than 182 centimeter. IBP console. The console serves as a control unit for the device and is responsible for inflating and deflating the balloon in coordinated manner. It consists of monitoring unit, control unit, gas source, and valve unit. The monitoring unit receives the data from the patient, that is ECG, infrared blood pressure monitor. Control unit uses this information to inject and retrieve the gas. The monitoring unit displays the systemic and the augmented blood pressure and allows for monitoring of the device's function. The control unit allows for the modulation of the balloon's ratio of supported bits. The number of supported bits is inversely proportional to the support that balloon is providing. That is, if the balloon is in 1:1 mode, each bit is being supported, and when in the 1:2 mode, only every second bit is supported. The monitoring unit is also permits the observation of the device's functionality. The normal tracing of 1:1. The user will be able to observe and incorrectly triggering IABP by looking at device's monitor tracing or waveform of the patient's heart. The control unit will read the data from the monitoring unit and inject the gas into balloon during TP interval of the ECG and will deflate during QRS interval when ECG trigger mode is used. Now, regarding IABP insertion technique, the IABP is most commonly implanted through the femoral artery. However, alternative sites include brachial artery, axillary artery, subclavian artery, and the iliac. Long-term IABP implants may also be placed into the operating room using surgical cutter. The IABP is typically placed under fluoroscopic guidance but can be inserted at bedside as well. Proper placement should be confirmed by chest radiograph before the use. Radio-opaque metallic marker on the distal tip of the IABP is used to assess the placement and should be 2 centimeters superior to the current, which approximates the area of the takeoff of the left subclavian artery in the most. An alternative landmark that clinical practices frequently use is aortic nerve, with the IABP tip located 1 to 2 centimeter distal to the aortic nerve. Of note, some operator may place the IABP using 9 French sidearm sheath, which allows for pressure transduction of the side, serving as a backup in the event of failure of primary pressure measuring system. Once the balloon's location has been confirmed, the gas lumen of the balloon must be checked to ensure the absence of the blood, which would suggest the balloon rupture. Once completed, the console is set and therapy is initiated. So this is the pictorial representation of the Iabp in systole and diastole with the ECG tracing, arterial augmented waveform and corresponding Iabp tracing. So the Iabp function to inflate during diastole and deflate during systole. This can be accomplished by the timing related to ECG or pressure waveform as pictured above to accurately inflate during appropriate portion of the cardiac cycle. The IBP waveform pictured in blue is timed to correlate vertically with diastole in the arterial and the ECG tracing. So this is the normal and the abnormal waveform as shown in the A. It is the normal IBP tracing. So the correct inflation timing is in the during the diastolic augmentation. So B is suggestive of the early inflation where where there is a loss of proper V-shaped form of the line. Then the B is late inflation, C is early deflation, and the E is early late deflation. So regarding IBP triggering, ECG trigger, the IBP is meant to inflate during and closing of AV and inflate during the closing of the AV band and deflate during its opening. The ECG trigger option is the preferred and generally most relevant. In this mode, the R wave on the patient's ECG corresponds to the opening of the AV and onset of systole. This triggers the deflation of the IV. IVP then senses the middle of the T wave on the ECG, patient's ECG, corresponding with the diastole and triggers the inflation. Arrhythmia can impair the IBP's ability to trigger the inflation, as can low ECG voltage, improper electrode placement, and electrical interference with the ECG signal. It is important to ensure the proper electrode placement and that the lead with most prominent R wave is selected and fixing the underlying cause of arrhythmia. If the issue persists, the IBP can be set to different trigger option. Atrial fibrillation trigger. If the pressure is in atrial fibrillation, an atrial fibrillation trigger mode can often be used, which triggers the balloon deflation at each R wave, despite variability between the complexes. Regarding pressure trigger, it is often used when the ECG quality is poor. The arterial waveform can also trigger inflation and deflation of the egg. In this mode, the dichrotic notch in the arterial waveform triggers the balloon inflation, and the point just before systolic upstole will trigger the deflation. This mode can be used during cardiopulmonary resuscitation because the arterial waveform should be generated by effective chest compression. Regarding internal trigger, the IVP can be set to intrinsic and asynchronous rate without physiological trigger. This mode should only be used in situations where cardiac output and ECG tracing are absent, as in case of systole or in patients supported on cardiopulmonary bypass. Pacer trigger, pacing spike can also be used to trigger IVP inflation. IVP is triggered to inflate by V pacing spike. This mode can be safely used if the patient is 100% pacer dependent. Now the auto mode. Auto mode is the feature that is capable of automatically discerning and choosing the most appropriate ECG lead and triggers and set inflation and deflation time. This mode is also able to respond and select the appropriate trigger in arrhythmia. The simplicity and safety of the auto mode makes this generally the best operation mode of choice for transport provider, minimizing the potential for the error. In comparison, semi-auto mode requires that provider establishes the timing and then device console automatically adjusts the subsequent timing to patient's heart rate rhythm and that provider select the lead and the trigger source. Diagnosing and troubleshooting the IBP complication. IBP failure alarm. This alarm suggests the intrinsic failure when the IBP console or Considering reinitiating console or computer device or changing the device if necessary after the troubles. When IBP disconnected alarm, this alarm suggests the disconnection of IBP extension tubing. Ensure the IBP extension tubing is connected and refilled with the gas. Rapid gas loss alarm. This alarm suggests the leak within the IBP circuit or hole or leak in the bulb. Because IBP is closed system, leak may cause the balloon's waveform to begin to fall below the baseline of 0. Some manufacturer may have pump rupture or autofill failure alarm instead. Verify connections are without. Examine the catheter for the blood and the coffee ground like material. If this is observed, the integrity of the balloon has been compromised and the likely needs to be removed. Stop the pump and prepare for removal and place replacement on the arrival to the receiving center. CCTM providers should be prepared to increase the support for patients, reduce the function of their IBP. Take IBP catheter alarm. This alarm suggests the kink in the IBP tubing or catheter. If sheath IBP was placed, it is possible that IBP is partially retained in the sheath, hampering inflation of the balloon. This alarm could also sound if IBP has not fully unfolded in the outlet. The balloon pressure waveform may have rounded peak rather than flat plateau. Check the IBP tubing and catheter and removing any kinks. If sheath IBP was placed, check the marking on the IBP to determine whether displacement has occurred. Transport provider should not manipulate the IBP insertion depth, and if displaced, should notify the receiving facility providers. Low helium alarm. This alarm suggests the helium supply is running. Replace the helium cylinder and ensure there are backup cylinder available to avoid prolonged pause of the IBP between the cylinder change. Some manufacturer may have autofill failure alarm instead. Certain IBP models provide for the rapid helium refilling when the pump console is separated from the cart. In most transport scenarios, helium may be rapidly refilled within a minute if console is reconnected to same model. Augmentation below limit set. This alarm suggests either augmentation is set too high or there has been change in the patient's hemodynamic status. Assess the patient for decreasing the cardiac function and worsening the vascular system resistance. And add inotrope and the vasoactive agent as needed. Assess for improving cardiac function and considering decreasing or removing IBP if appropriate. Consider decreasing the alarm limit if other clinical data suggests the patient is adequately supported. No trigger. This alarm suggests the IBP is unable to sense the trigger mode that has been selected. There are various trigger modes that may be useful in different circumstances. Troubleshooting will be based on the trigger mode being used and may require changing to different normal and abnormal IBP. So timing area, correct the timing of the inflation and deflation cycle of the IBP is correct, is critical. If a balloon is not adequately timed to inflate and deflate in sync with the patient's cardiac cycle, it can impair an already dysfunctional air. Timing is assessing 1:2 mode so that pressure differences between the augmented and non-augmented beats can be observed and used for diagnostics. The correctly timed IBP should result in arterial waveform that shows inflation occurring at diachrotic notch and forming a sharp V shape. The slope of the augmented diastolic pressure should be parallel to and reach peaks higher than the previous systolic upstroke. Assisted end diastolic blood pressure should be lower than the previous unassisted end diastolic blood pressure by 15 to 20 mmHg. Finally, the peak of assisted SPP that follows IBP inflation should be 5 mmHg lower than the previous unassisted SPP. Error with the timing causing either early or late deflation or inflation or deflation can be detected by variance on the arterial wave. Early deflation. Early inflation will cause IBP to inflate before AV has closed. This has the potential to cause AV to close prematurely because of increased afterload, leading to impaired LV emptying and causing possibly aortic regurgitation. Incomplete LV emptying will lead to increased LV end diastolic volume, LV end diastolic pressure, and pulmonary capillary wedge pressure, which will increase the myocardial oxygen demand. Early inflation will lead to diastolic augmentation occurring prior to the dicrotic notch and loss of desired vision. The diastolic augmentation may encroach on the unassisted systolic peak to such a degree that two peaks become difficult to differentiate. Early inflation can be corrected by adjusting the timing so that IBP inflates and dichrotic notch. However, best solution is to use auto mode to optimize the timing rather than manually manipulating this variable in the critically ill patients. So this diagram is the representative of early inflation. Late inflation of the IBP occurs well after closure of the AV. This has potential to cause inadequate perfusion of the coronary artery due to suboptimal diastolic augmentation. The arterial waveform will show IBP inflation occurring well after dichrotic notch, again resulting into the loss of optimal vision. The augmented diastolic blood pressure may be equal to or lower than the unassisted SPP. This can be corrected by adjusting the timing so so that IBP inflates and dichrotic notes. However, similar to suggestion for remedying early inflation, auto mode should be used rather than transport provider manually altering variable of the concern. This is the diagram representative of the late inflation. Now, early deflation of the IBP during diastolic phase and before isovolumetric contraction occurs. This decreases the efficacy of the IBP to reduce the afterload, reducing boost in the CPP, and obviating the potential reduction in the myocardial oxygen demand. Early deflation may lead to retrograde coronary and carotid blood flow due to vacuum-like effect in the mid system. The arterial waveform will show the sharp drop in the pressure soon after the peak of diastolic augmentation. The assisted SPP may be equal to or higher than unassisted SPP, and the assisted end diastolic blood pressure may be equal to or less than the unassisted end diastolic blood pressure. The early deflation may be corrected by prolonging IBP inflation time, although auto mode typically accounts for or corrects this error. This is the diagram showing the early deflation. Now the late deflation. Deflation should end near the end of the diastole during isovolumetric contraction. If IBP deflation is prolonged, it may still be in the process of deflating after the AV has opened. In this scenario, rather than reducing afterload, the resistance from self-inflated balloon during systole will increase the afterload, interfering with LV ejection and prolonging the isovolumetric contraction. This effect will increase the myocardial oxygen demand. The characteristic arterial waveform of the late deflation will show assisted end diastolic pressure that is equal to or greater than unassisted end diastolic pressure and widened augmented diastolic peak. If late deflation occurs, the IBP inflation time should be short, although auto mode typically accounts for and corrects this error. There are several alarms common to various IBP brands. It is important for the provider to be able to recognize the potential cause of this alarm and to address it. This is the diagram representative of the late deflation. Now, in setting of cardiac arrest, IBP support may be continued. The ECG trigger becomes dysfunctional and cannot be used as the primary timing source. In shockable rhythm, there are no discernible organized rhythm. Interestingly, in situations where patient is in pulseless electrical activities, the IBP will continue to sense the organized rhythm. However, during compression, there will be significant artifact. The pressure trigger rather than the ECG trigger is preferred sensing method in this scenario. In transport setting with small number of providers, this can be accomplished by simply disconnecting ECG lead from the pump console. The patient's underlying cardiac rhythm still be monitored through primary cardiac monitor using electrode or pads. Defibrillation can be safely performed with Iabp device function. Thank you.